recognizing that there is a lot of emotional and political well, a lot of feelings of different kinds associated with the discussion of this policy, I thought, well, how can I, as an outsider, coming from the frozen north, provide information that would be useful to your deliberations, and that would perhaps provide you with something that you hadn't seen before. And so I looked through the Commission's bibliography to find if our material, for example, had already been considered by the Commission, and I didn't find it there. In fact, I found very little there of an examination of the practical consequences of the healthcare model that they were proposing. Because indeed, the only country in the world that has a healthcare model of the kind which is proposed by the panel is Canada. And so what I'm going to do today is take you through a consideration of, from 2 points of view, of some evidence which I do not believe has been before you as you've been considering this important future for your healthcare system and for your economy. I hope that it will give both you and your government some food for thought as you make what will be an historic decision. Whatever you do, it'll be a historic decision. Now, I have essentially 4 parts to my presentation. The first is, why should you listen to what I have to say? I think it's important for us to get that out of the way. The second is to put healthcare in a broader policy context, because although you're seeming to make a decision about healthcare, in fact, you have to see healthcare policy in the context of broader policy discussions. And then I want to drill deeply into the Canadian healthcare system and to discuss both the myths and the realities of its comparative performance. And then finally to just make a few comments about the futures for Bahamian policy which are contained in the Blue Ribbon panel. Well, why should you be interested in listening to me at all about this or any other topic? Well, I think the main reason is that what is being proposed here is essentially a Canadian model. Now, I've been researching the Canadian healthcare system in various ways since 1978, and for 17 years, my colleagues and I have been actually producing measurements of its performance, which are more or less unique. But finally, and most importantly, I think, is that the evidence which we have been compiling over the past 17 years was recently used by the Supreme Court of Canada to find that the Canadian healthcare system as it exists is violating the constitutional rights of Canadians. And they came to that conclusion because of the determination that people's health care was being damaged by the provisions of the program, on the one hand, and secondly, that damage was not necessary to sustain a social, universal, comprehensive insurance program of the kind which the Canadian system has. So in other words, the court said, you know what, the Canadian system isn't working all that well, and the provisions of it which are making it not work all that well are not necessary. And so that's probably the main reason why you should be interested in listening, not only to me, but to others who would come from Canada and give you information about what's actually happening in the Canadian system. Now I'm going to move away from that. That's by way of a teaser, so this is to keep you on the edge of your seat and anticipating what is going to come. I'm going to back away from that now and go into the broader policy question. Because one of the things we recognize is that wealthy people and nations tend to be healthy. This is one of the most widely, I think, accepted ideas now in policy analysis, that wealthy nations are healthy in part because they can afford all of the infrastructure that keeps our inflow separated from our outflow, which is the main problem we have around the world, that people's water intake is being contaminated by their effluent. And so wealthy countries are able to deal with that major issue, and so that's one reason why they tend to be healthier, but also because they can afford to have healthcare systems that help them when they're not feeling well, and so on. Of course, there is a correlation between wealthy people and healthy people, because for the same reasons they can afford that, but also because perhaps there's something that makes them both wealthy and healthy. That is a different approach to life, that they have different habits than people who are not wealthy and healthy. And that's something that's very important to take into account, by the way, when you're wondering what you can solve. You know, there are some problems you can't solve. This is one of the things that you learn. I've been in the policy business now for about 40 years, and one of the hardest things and most difficult things to accept is that there are some problems you can't solve. You can't help somebody who doesn't want to be helped. You can't help somebody who has got a bad lifestyle choice, has made a bad lifestyle choice, which is impinging on their health. You can't help that person. You can help them try to make different choices, maybe, but once they've made those choices, you can. So we have to be cognizant of that while we're grappling with this. But let me get to this. Let me get to this logic that I wanted to lay out here. Wealthy people and nations tend to be healthy. Policy can increase the health care access of the less wealthy by taxing the income of the wealthy. If you have a group in your society who want to be healthy and are making healthy choices, but don't have the wealth to get access to health care when their body deals them a trick, or they get a microbe or something, then of course you can solve that problem by helping people who are less wealthy, and you get that money from people who are more wealthy. Now, there's a bit of a problem with that, however, because human and financial capital try to avoid taxes. And the competition for both kinds of capital is global. So that when you're thinking how much money you're going to take from the wealthy to give to the less wealthy, you got to remember that the wealthy don't have to stick around. And in particular, if you're taxing capital to do that, it surely doesn't have to stick around. So, you know, we all recognize that it's a good idea to do some of this redistribution to help people who want to be healthy to stay healthy. On the other hand, you got to watch that other side of it. Nations which attempt to solve the health problem of the less wealthy by taxing human and financial capital will attract less of both. This is now no longer in any dispute around the world. Everybody recognizes everywhere in the world, in the former Soviet Union, in China, everybody in the world now agrees that, yeah, capital moves away and people won't work well if you tax them too much. So therefore, policy which pursues gains in population health without careful attention to the growth and per capita income effects of the methods chosen may produce short-term gains at the expense of long-term losses. And this is very important. So now I'm going to look at the broader, the broader policy context in the Bahamas. Now, how has Bahamian policy been doing generally with regard to this issue of attracting human capital and you know what I mean by human capital, right? I mean somebody who, you know, invests a lot in their education, all that kind of stuff. Do they stay here or do they go to Miami? That's what I'm talking about. Do they decide to stay here or do they vamoose? And that is a, you know, and when of course I don't have to tell you about what we're talking about on the capital side of things. So what we need to do is to assess what the general policy context is in the Bahamas before we get down to drill down to the issue of health policy. Now, for years, the Fraser Institute, in conjunction with institutes in 70 countries, has been measuring policy in about 130 countries. Now, we didn't do 130 countries right at the beginning. We could only measure 80 because there was no data for all 130 at the beginning. But now we're measuring about 94% of the world's population, the policies to which they are subject by their governments. And I'm delighted to see James Shakwati here. He's one of our partners around the world in this exercise. The measure the measure that we use has 38 different measures of policy, which it scores on a 1 to 10 basis. And then that enables us then to rank the countries from best policy to worst policy. And what I'm talking about is how high are the personal income tax rates? Are the regulations making it difficult for people to get employed? Are there big taxes on trade? I'm not talking about airy-fairy stuff. When it comes to things like property rights, are the judges independent? Or when you go to sue somebody, do you find that the judge is the uncle of the guy that you're suing? Or that the judge has been paid off by the guy that you're suing, and so on. I mean, these are real issues. When these are important issues to deal with. And we take these measurements from the World Bank and from a variety of sources to produce these rankings. So, how has the Bahamas done in this regard? Well, unfortunately, not well. The Bahamas in 1975 was in the top 20 of countries around the world, where countries like Canada and Hong Kong and Iceland and Ireland and Luxembourg and New Zealand and Singapore and Switzerland and the United Kingdom and the United States are today. It was way up there, as you can see. And during the course of the past, well, in particular from 1975 down to 2000, policy deteriorated. And when we look at the policy ranking for specific areas, we can see where the deterioration has happened. It hasn't happened too much in the size of government. The size of government, although it's becoming less competitive, it's still in the top 20. Regulation is not bad by comparison with other jurisdictions, although I must say that the precision with which we can measure the Bahamas is not as great as the precision with which we're measuring other countries because the data is not available for the Bahamas. This is a problem which I'll return to a little later. Where the Bahamas has really shone is in the protection of property rights and the rule of law. The Bahamas is an example, as a matter of fact, to other countries as how you can actually improve over a period of time the access to the rule of law and the protection of property rights in a country. In the area of monetary policy, of course, the fact that you've got exchange controls gives you a big black mark on your copybook. Exchange controls are very, very bad. They're bad from every point of view that you can possibly imagine. In particular, they're very bad when you're trying to get capital to come in. You know, I mean, people are not stupid if you say to them, okay, bring your money to us, and once you get it here, it stays here. You know, well, maybe that's not such a great way of attracting money. And in trade, you get bad marks because of your very high tariff rates, 35% tariff rates on imports. And that's a real issue going forward, I think, for your country. And the other one is, well, it's the tariff rate here. I've spun that out, the tariff rate, along with the ranking on trade policy. So that's how the government of the Bahamas, generally speaking, has been doing. And as you can see, there's one good story here, but mostly it's in the wrong direction. The policy is deteriorating gradually over time, and this is not a good harbinger for the future. Now, why am I spending time on this? I'm spending time on it because the quality of policy really, really matters. Let's look globally. Let's look at around the world at these 130 countries that we measure and see what the consequences of different kinds of policy have been in those countries. And what we're doing here is we're showing we take all the countries in the world and we line them up from worst policy. And when I say worst policy, I'm not doing this, by picking this out of the air. What we're doing is we're measuring all of the countries. We're measuring their tax rates, we're measuring their regulations, and so on. And then we're simply taking those measurements and saying, okay, high tariffs, high tax rates, a lot of regulation, a lot of corruption of judges, a lot of problems with inflation and controlling the money supply. That country will go right down at the bottom. Okay, and then we move gradually till we get to a country like Hong Kong, which of course has got some problems. But it doesn't have many problems in the area of economic policy or in the rule of law, in the protection of the assets of the people who invest there and so on. And they're up at the top end. So now we take all of those countries and then we group them into quartiles and say, okay, let's look at the worst, the lowest, the worst performer, the worst policy. Let's look at then the best policy. And what we're going to do is look at a variety of associations with those policies. So here we're looking at, for example, per capita income. So what do we find? We find that, not surprisingly, that countries that have the worst policy and are grouped together, gee, their average income is very low. The countries that have the best policies, you group them together, they have an income which is very high, because good policy produces higher levels of income. The same is true with levels of growth. Here we have actual negative growth in the worst policy countries. From worst policy to best policy, you get an increase in growth as you improve policy. Now here's something very important. The best policy countries are also the ones that have the lowest levels of human poverty. And the worst policy countries are the ones that have the highest level of human poverty. Human development, the United Nations measure. By the way, all of these measures that I'm using here are from the United Nations in one form or another. And this is the United Nations Human Development Index. Once again, the countries that produce bad policy produce bad human development. Why are we surprised? Policy have high quality of human development. Now this one is very important from the point of view of the discussion that we're having here today about healthcare. This is life expectancy. And you know, whatever else can be said about it, you can't have much quality of life if you don't live very long. You know, it's sort of rudimentary. And the countries where there's low quality policy, gee whiz, 60 years. Average life expectancy of 60 years. The best policy, nearly 80 years. And so there's a huge, big, measurable, tangible consequence for ordinary people in their lives from living in an environment where there is good policy because they just live longer. I like to show this one because you know, if there's anything, any people who don't have children, I suppose, can realize that it must be the greatest tragedy that a family can have to lose a child in infancy. And this happens in bad policy countries to the tune of nearly 1 in 10. It's 80 per thousand live births. Whereas in high quality policy countries, there's almost no infant mortality. Once again, I mentioned before about the quality of the water that people drink. Well, one of the things that produces cleaner water is a better policy environment because it produces greater wealth and therefore a greater ability to deal with those kinds of problems. So that's by way of background, that the quality of policy really matters, and it really matters for Bahamians. And we can see the effects of the policy decline that I mentioned before in the results for the Bahamas. We don't have very good data. This is the data coming from the World Bank. Unfortunately, the World Bank doesn't have data beyond about 2000. At least I couldn't find any more data beyond 2000. We've been looking for quite a long time. And even at this moment, when I went to their website last night, there was no new data for the Bahamas for per capita income, real per capita income beyond 2000. But you can see that this is the rank of the Bahamas in the world. In 1970, the ranked higher than 20th in the world. Today you fall into nearly 30th in the world in terms of per capita real income. And this is not the kind of trend that you want to encourage. This is not a trend that you should feel comfortable about. This is a trend that should set off alarm bells, because it means you're falling behind the rest of the world. When we calculate, and even more distressing is this chart, which shows the growth rate. When we calculate the average growth rate from 1970 to 1985, and from 85 to 2000, and you might say, well, why did I make that break? Well, I took the first half of the period and the second half of the period to see what the growth rates were. And in 70 to 85, the average per capita growth rate was 1.27%. That is, that you were adding more than 1% every year to the real income that an average Bahamian could enjoy. That growth rate has fallen to almost 0.06 per year in the latter part of that period. So this is something, once again, that you should be concerned about. Because whether it's health care, whether it's education, whatever it is that you want to achieve for your population, you can't do it if you don't have the resources to do it. And this is coming from, got to come from economic growth. So the decline in policy quality is showing up in lower average incomes and lower growth rates. Apart from any other development, this is going to reduce the comparative health status of Bahamians. It's worth just resting on that point for a moment. That whatever else you do with your health policy, whatever you jigger around, the fact that you're less wealthy and you're getting less wealthier than other people in the world means that your health status, because wealth affects health, is going to deteriorate relative to the rest of the population. Now, why am I raising this and making such a, and berating you about it? And, you know, because I see that people are starting to get an attack of horizontal neurosis already. This is a virus that I take around. I seem I carry it in my handbag or something in my briefcase here, because when I go to lectures, people, you know, usually after about 10 minutes, there's a certain sort of glazing of the eyeball, you know, and then it goes from the eye, the mucosa of the eye into the muscles that hold the eyelids up, and different people cope with it in different ways, and I've been watching very carefully. You know, some people will sort of, you know, cover up one eye, oh, you know, and then they move over and then they cover up the other one, oh, and I can always hear them saying, you know, my God, how could anything so small weigh 400 pounds, you know? And so I've been watching. I mean, my children added one to that. They said, Dad, one part that you forgot was the end stage. And what is the end stage? Well, the end stage is that you get what is called the woodpecker syndrome. You know. and the head keeps wanting to drill holes in the table, or in the back of the head of the person in front of you. But anyway, so I've been watching for that. But so why am I belaboring this point? Well, ladies and gentlemen, as I'm going to show you later, the Blue Ribbon Panel, although it doesn't talk about this in any great detail, is proposing a new kind of tax in the Bahamas to pay for this healthcare system, and it's an income tax. And the income tax, I can tell you, is going to be I'm going to show you some data later on from Canada to drive home the point about what your future will be around this tax. Because at the moment, it's good, the taxes introduced will be small, but it will become the most significant tax that you pay in the Bahamas. And it is going to make it more difficult for you to attract human capital, because your young people don't have to stay here. You already know that. They don't have to stay here. They're not getting the kind of opportunities here in the Bahamas that they should get. And they're leaving. And they're going elsewhere to find their opportunities. They're going elsewhere where their human capital is more highly regarded. And this kind of tax will make that exodus even more profound. And of course, the other kind of capital, well, you already know about that. That if you try and tax that, and of course it's not proposed at this moment to tax it, but when I show you the figures from Canada, you will realize that pretty soon governments will be, and when I say pretty soon, I mean over the course of the next 10, 15 years, your governments will be scrambling to get their hands on more dough to finance what they're proposing. Okay, now let's look at the Canadian case. So that's background. You got to be very careful about the choices you make about your healthcare policy, because it's going to come to dominate the whole quality of your policy, and you've got a problem. But now let's go and look at a real live world example about which we've got a lot of data and experience of what it is that the Blue Ribbon Panel Commission is actually suggesting. We are the only country in the OECD that has exclusively public sector single payer for health care. The Canadian system needs to be carefully studied before launching a plan, because it is the only real live example of what they're proposing. And what I'm going to show you is a set of measurements of the Canadian system, and these are among the measurements that caused the Canadian Supreme Court to rule that the provisions of the sort of system that we have were injurious to the health of Canadians and violated their constitutional rights. Now, you would have thought there would have been more attention paid to, I must say. You would have thought that there would have been at least passing mention made of that here in the Bahamas as you propose to go down the same path. Why would the Supreme Court, which, by the way, is redder than the hind end of a baboon going, the north end of a baboon going south, in terms of its general approach to the world, why would the Supreme Court have made such a ruling? And the reason is what I'm now going to show you. When you're talking about health care costs, you have to be very careful, particularly if you're comparing countries, to make an adjustment for the age of the population. Why do we have to do that? Well, because as you descend into old fartdom, as my son keeps telling me I'm doing, your body starts to break down, and you need more knees replaced, hips replaced, you need all that stuff. Your heart doesn't work properly, you need more medication. So it gets you get more expensive as you get older from the point of view of health. So if you're looking at a healthcare system such as the Bahamian healthcare system, which has very young population, you can't compare that to Great Britain or to Germany or to Italy without making an adjustment for the age of the population, right? And so that's what we do in all of our calculations. We age adjust them so that we don't fool ourselves into coming to conclusions which are simply a reflection of the demographics. And when we make those adjustments, we find that the Canadian healthcare system is amongst the industrialized nations of the world, other than Iceland. Iceland is really a special example, although it's an example you might want to look at because it's got a population round about the same as the Bahamas, round about the same. They have a universal healthcare system, just like the Bahamas. They have a slightly, the age of their population, I'm not sure. I think it's more like Canada than it is like the Bahamas. But there's the cost of their system. It's nearly 13%. That would be about 13% of their GDP. It's, in other words, about double the cost of the Bahamian system at the moment. About double of what you're paying here in the Bahamas at the moment. Canada is getting right up there. We're up at about 11% of but of the industrialized countries, the major countries with a major population and all those kind of things, we are the most expensive. We always say that, we're the most expensive industrialized nation because it's not clear that it's appropriate to compare something like Canada with Iceland. It's not appropriate, I think, to compare Iceland with almost anybody except maybe the Bahamas. Because of the size, you see, because it's a different kind of problem. Now here's the cost. This is what's been happening to the cost, inflation-adjusted provincial and territorial spending per person in Canada on health care. And I'm showing you this graph because enough money on it. Of people say that, the reason why the Canadian healthcare system has got problems is because we're not spending enough money on it. Those terrible conservatives of whatever stripe, they are cutting back the money for the healthcare system. That's why we don't have good health care. Well, nothing could be further from the truth. It's, this is, if you were looking at anything, if you're looking at the cost of your budget in your personal affairs, you would regard that as an alarming trend, and with good reason, because as I'm going to show you later on, there are some real issues associated with that. But first of all, let's now ask the question, are we getting the results that we're paying for in Canada? Here we have the most expensive in the industrialized world. Oh, and by the way, I got to go back. Got to go back for a couple of reasons. One is the only countries that we're looking at here are countries that have national health insurance systems. For that reason, I don't have the United States here. The United States is more expensive. But it's not saying I'm going to provide universal access, socialized medicine. They have a very different kind of system. But all of these other countries have the same kind of objective as Canada does, and the objective which is expressed in the blue ribbon panel. Now, I want to draw your attention to the United Kingdom, which is way down here at less than 8%, a very cheap, cheaply run system. In fact, they're spending about the same amount as you are currently in the Bahamas spending. But what's the difference between the United Kingdom and the Bahamas? Is that you are very young and they're very old. So when they're spending that amount, they are, they're contending with a very much bigger healthcare problem than you've got here in the Bahamas because of the age of the population. So just remember that when we go forward here, that United Kingdom they're spending a lot less on healthcare than all these other countries that we're interested in. Now let's go back and look at Canadian results. We're the most expensive. Are we getting what we pay for? Well, let's look at waiting times. These are the waiting times that you can expect across Canada. And one of the first things you notice about this, what is the first thing that you notice about this chart? These are the different provinces of Canada. Anybody tell me what the first thing you notice about it? Just looking at the length of those lines? That they're different. We don't have the same access in Vancouver as they have in Ontario. We don't have the same access in Prince Edward Island that we have. We have a lot of different kinds of access, right? So that should tell you right away that whatever you think and whatever they promise, you are not, ladies and gentlemen, going to get universal, same access right across all of the islands of the Bahamas. You're not going to get it. We've been trying for nearly 40 years to do it, and this is the result. You have big differences in the access to care across the provinces. Now, this is the kind of things that people are waiting for. The Department of Health in Canada a couple of weeks ago issued a special bulletin when we released our waiting list things for plastic surgery. The report was by the Department of Health that there had been an outbreak of ugliness. No, not at all. Of course, this is not cosmetic surgery. This is for people who have cancer of the face or have things where they have to have reconstructive surgery done, and these are the kinds of waiting times that they're experiencing. So you should take a good look. You would have thought that the Blue Ribbon panel would have given some attention to this, and the fact that we've had a huge national debate in Canada about waiting lists, and that every province has now got a special program to deal with waiting times, and that the government of Canada has got a plan to deal with waiting times. And of course, it's all a plan, but these are the results. And what has happened since 1993 when we first got this survey that we're doing now? And by the way, this comes from surveying a very significant fraction, up to 50% of all of the practitioners, specialist practitioners in the country. This is not I wonder what the waiting times are. We're actually measuring the waiting times by the people who in Canada keep the waiting list, namely the specialists. And we've been doing it for a long time. And you can see the red bars, we're not doing well in terms of getting this under control. These are the increases that have happened since 1993 in the length of the waiting time. This is the gap between the reasonable waiting time and the actual waiting time. Reasonable, what does reasonable mean? We ask the physicians to tell us what is the time that is clinically reasonable. That is to say that waiting will not impair the health of the patient. Because there is, you can wait. If you've got a thingamajig on your whatchamacallit, you can wait for some period of time, right? You don't have to get it done tomorrow. But if you got to wait for 5 months or a year and a half, your health care condition deteriorates. In fact, in some cases, if you wait more than a couple of weeks, your health care, if you're talking about chemotherapy for cancer, if you're talking about radiation therapy, or if you're talking about, there are a lot of things, you're talking about surgery for it. So when we average that out, what we're discovering is that there's this big gap between the reasonable amount of time that people, the reasonable amount of time people should wait and the amount of time that they're actually waiting across all surgical groups. Well, we also measure the waiting time for diagnostic technology, and this includes MRIs, CT scans, ultrasounds, and so on. And these have been starting to come down. And why do you think that? Can anybody hazard a guess why these have been starting to come down? Well, because of the advent of private clinics that are offering MRIs and are now, the government is now having to ignore them. For a while, they tried to stamp them out, wouldn't give them licenses, wouldn't, I mean, the most incredible array of things to stop people from delivering healthcare services to people. Huh? What? No, but that's what they were doing. Now they've stopped that because, you know, the Supreme Court has made it a little more hazardous for them. If they're now stopping it, now they can be taken into court and be said to be injuring the health of Canadians. So they've stopped that, and so these things are starting to drop. Well, that's just another way of measuring the same thing. Now this is talking about the United Kingdom in the report. There's a lot of references to what's going on in the United Kingdom. The kind of references that are to Canada are the references produced by Ms. Woolhandler at Harvard, same school but different people, suggesting that the administrative costs of the Canadian system are very low. But no mention about any of this inconvenient truth, to use a inconvenient truth about what's going on with regard to our healthcare system. Well, okay, now let's look at, so that's waiting times. Now let's look at access to doctors and technology. And I'm going to go through these quickly because, as I pointed out, I'm way behind. Canada, 24th in the OECD with regard to access to doctors. 13th with regard to access to MRI machines. 17th with regard to CAT scanners. You'll notice up here I've got Japan up here because they would be way off the chart. 78.4 per million population. There's one in every corner store in Japan, as a matter of fact. This is the truth of CT scanners. But they have a very relatively cheap healthcare system nonetheless. But 17th for Canada. Mammograms in the OECD. 7th. Lithotripters, 18th. So in other words, from the point of view of access, we're 24th of 28 countries for access to physicians, 13th of 24 for access to MRI machines, 17 of 23 countries for access to CT scanners, 7 of 17 countries for mammograms, and 18 of 20 countries for access to the lithotripters. It's absolutely clear that Canada is the country that they should have selected, right? Isn't it? I mean, it's unbelievable. Now let's look at healthcare outcomes, because this is where, as they say, the rubber hits the road. Life expectancy and full health in the OECD. Now, you would have expected that the most expensive healthcare system would have produced some higher numbers. But here we are, 16th. And by the way, these are not our numbers. These are the OECD. The OECD does these careful measurements. We have close and ongoing cooperation with the OECD, but they produce these numbers themselves. And you can see that not great. Infant mortality, we're 21st in the OECD. Perinatal mortality, we're 14th in the OECD. Mortality from disease. Now you might think, well, what else do you die from? Well, you die from, you know, jumping off buildings. You die from automobile accidents. In fact, most of our young people die from automobile accidents, and but we're 8th in mortality from disease. Wouldn't you expect us to be up here number 1? I mean, we're paying more than anybody else. Potential years of life lost. This is years of life which are preventable, which we lose and we shouldn't be losing. This is years of life which could be saved if we had appropriately with our healthcare system. This is medically avoidable mortality. This is where you actually get access to care, and it's not, you know, you could have avoided it, but you didn't. So we're not doing too badly there. When we do intervene, we're not actually killing people at a very high rate. in our healthcare system. This is the breast cancer mortality rate in the OECD, 10th. This is one of the ones where we shine in colon rectum cancer. We have a lot of jokes around the Institute about why that is in Canada, but never mind. Shouldn't make jokes about people dying, I guess. Okay, so are we getting what we pay for in Canada? We have a high-cost system. We have worsening waiting times. We have poor performance on waiting times for elective medical care. We have poor results on access to doctors and technology, and mediocre performance on healthcare outcomes. Well, now, what is the problem? The problem is that the policies that we have in Canada. Now, I've got to go through this relatively quickly. I'm just going to mention them. When we look at user fees, for example, we don't have any user fees. They're outlawed. But in fact, 80% of the countries in the OECD do have co-payments, deductibles, and user fees in some of their activities. Canada is not one of them. Providers of public health care in the OECD. We have, in fact, total public ownership of our institutions. One of the consequences of that is that, for example, in the province of Ontario, the average age of a hospital is 40 years. The average age of a hospital in the United States is 9 years. If the public does it, then, you know, the capital allocation process is politicized. You don't get the kind of vibrancy and the kind of forward motion that you get when you have private capital involved. But you can see that within the OECD, about 60% of the case is mixed ownership, and in 40% it's public ownership and public management. So there is quite a lot of that in the OECD countries. Is there a private parallel healthcare system available? Not available in Canada and the Czech Republic, available everywhere else. And I'm going to come back to this because there is a very, very important clause in the proposal by the Blue Ribbon Commission, which would in effect put you in the same camp as Canada and the Czech Republic. And I'm not sure that this has gotten a lot of attention in your country, because if you weren't actually living with a system that has this provision, you wouldn't recognize it as being as sinister as it actually is. And I'm going to come back to it, but that, once again, it's a way of keeping you on the edge of your seat. What is a sinister thing lurking in the Blue Ribbon Commission's report? Well, there is something lurking there. Well, is Canada unique? Well, it is in a way. Only 2 of the 28 countries surveyed have no comprehensive private provision of health care, Canada and the Czech Republic. Canada is the only country to have full and complete public management of hospital resources and no private parallel insurance system. Canada is the only country to effectively outlaw private parallel health care. There will soon be another country on this list if you go ahead to do what you do, and that will be the Bahamas. Now, if I had more time, I would spend a lot of detail on these universal health care programs that actually do work. Countries like Australia, Sweden, and Japan, for example, that have lower health care costs, better health care outcomes, user fees or co-payments, parallel private medical care, and supply parallel private medical treatment and supply publicly funded care. So in other words, these are countries that you might want to model yourself after. If you were going to come up with a socialized option, look at Australia, Sweden, and Japan and see how they're doing it. You might also want to look at Australia, where cost sharing accounts for 16% of total expenditure, where the benefit is 75% for professional hospital services and 85% for other professional services. There are no controls on physicians' fees. There is extra billing, for example, though physicians who accept 85% of the schedule can bill the government directly. Private health care insurance cover is available, and which is community rated with tax incentives. So you would want to look very carefully at Australia. Sweden. In Sweden, the counties county councils deliver care. There's co-payments for physician services, hospital care, outpatient care, elderly care, dental, and drugs. Fees vary by county, but are capped. Now, less than 2% of the resources devoted to healthcare come from patient fees, it is true, but you do have to pay to go and see a general practitioner. And so people in Sweden are involved in the decision about paying for some part of the care, and I'll come back to this in a few moments. There is no gatekeeping, however. People can go to a specialist without going first to a private, to a family doctor. And in some of the counties, like Stockholm County, which is in some ways the most important one, they've got a publicly traded, rather a privately owned, publicly trading on the stock exchange hospital called St. Gorans, which is now setting the diagnostically related group pricing for healthcare in Sweden, and the performance of that county is superb by comparison with the rest of the counties in the country. You also want to look at these countries because they all have features that we think should be in a well-designed healthcare system and are not in the Canadian system. You would, for example, have lower or similar healthcare costs, no waiting lists. They do have user fees or co-payments. They have parallel private medical treatment. This keeps coming up, that these countries that do better have parallel private care. And can you think of any reason why that might be the case? Can anybody think of a monopoly that works well? No. And why is it because the people who run the monopoly are lazy or stupid or whatever? No. It's because they don't have anybody who's looking over their shoulder. It isn't that, I always have to point this out, it isn't that private business people are smarter than the people who work in the government. It's that everybody who's in the private sector has got somebody else who's looking at their business. Somebody from the outside who's constantly looking at their business to see if they can do it better, if they can make more profit than the person who's in it now. It's competition that makes the private sector work better, and the lack of competition that makes the public sector not work. And we would all be the same. If we were all in the public sector, we would behave the same as the people who are in the public sector. Well, because that's the way we are. That's the way human beings are. That's why competition works better than not competition. So parallel private treatment is available in all these countries. Social insurance does finance the healthcare systems in all these in these countries, but private hospitals are competing to supply publicly funded care. Japan, well, I'm going to run out of time, but these are some other examples. Switzerland's, I think, a particularly good example. There's compulsory insurance. There's compulsory. Everybody has to have insurance that's privately provided. There is risk redistribution within their system. They have deductibles that have to be paid by the patient. Direct patient payments accounted for 28% of total expenditures in Switzerland. But from the point of view of a healthcare system where you can get an instantaneous treatment for almost anything, you can't find a better system than the Swiss. It is, however, quite expensive. Not quite as expensive as Canada, but so you should look at the Swiss model. So then how good is Canadian healthcare as a model for other people? Less than top performance in healthcare outcomes, ranks at the bottom in access to care, supply of technologies and supplies of physicians, and ranks at the very top in spending. And as I've noted, the problem is we have got the wrong policy. Now, I now want to show you something about the economics. I am, after all, an economist. I said before that the Blue Ribbon Commission's report is a Trojan horse for your future. And I don't make that charge lightly, because I'm sure these people, were well-meaning, that they did a lot of work, and they thought, I think that they just don't realize what they're proposing. And I want to show you now some economics of the Canadian healthcare system to drive this point home. Now, I'm going to introduce you to two of my favorite characters, Trev and Fex. Trev is total revenue. Fex is public health expenditure. And on this chart, you've got our national GDP growth from 2000 to 2005. you got national, the consumer price index, you got consolidated provincial total revenues. That's TREV, TREV. Okay, and growing at 3.5%. This is consolidated provincial public health expenditures, growing at 8.1%. That's FEX, so TREV and FEX. Now here we see FEX and TREV by province. And you can see universally across the piece, with almost the exception of Alberta. Does anybody know what they do in Alberta? They pump oil out of the ground. Huh? They pump oil, yeah, they pump oil out of the ground. And they haven't been able to keep ahead. Even with pumping all that oil out of the ground, FEX is growing faster than TREV. Now, you know, TREV is sort of like a solution provider. FEX is like a problem. Because if your expenditures are growing faster than your revenues, you're eventually going to come a cropper. And here, if we compare it over time, we compare FEX and TREV by province from 1997 to 2005. You can see what's going on. It's not looking good. Now, in the case of the province, actually done some projections to see when it is, because if your total expenditure on health care is growing faster than total revenues, if you imagine this is a road race, total revenues are running along, and they're running at 3 miles an hour, and public health expenditures are running at 5 miles an hour, what's eventually going to happen? Healthcare is going to absorb all of the revenue in the budget. It's just going to happen. And so what we have done is we have made a projection of what's going to happen in the province of Ontario, one of our wealthiest, in fact, the wealthiest province in many ways. It doesn't have the oil in the ground, but it's got everything else going for it. And here is what's happening. This is what happens. This is FEX, and here's TREV. And now this is not just the amount set aside for health care. This is not the amount. This is total revenue in the province. And ladies and gentlemen, this line, this FEX line, when we projected that, we did not project the aging of the population. I'll just show you that it does not include the impact of aging population. It includes drug delisting, reform efforts, and rationalization. In other words, all of the things that we are doing to try to stop the growth of expenditure have been included. Total revenue has been overstated because we do not take into account debt servicing costs. The actual amount of revenue available is lower than we've been showing here, but because we're projecting total revenue. And total revenue includes federal transfers and includes tax increases which are already planned. So in other words, this is a very cautious projection, and what it shows is that Ontario in 2026, which is not that far away, total public health expenditures will absorb all of the revenues that are available. Now, is this going to actually happen? How many people here think that that's going to actually happen? No, of course it's not going to actually happen. But what is going to have to happen between now and then? Well, either tax increases or other expenditures eliminated, or some competition in the system, or you have reduced your health care available. Now, remember what I showed you at the beginning about what was happening to waiting times? If you were put in the position of managing the health care system of any of those provinces, and you're looking at that chart, wouldn't you be reducing access to health care? Not because you're a miserable SOB, but because you just are faced with the only one thing you can do. You've got a policy that says you got to give universal access to everybody, doesn't matter what, on the one hand, and by the way, you got to do it with that fixed amount of money. Well, how long do you think it's going to be before you find, well, I can't give it to everybody, so who am I going to give it to? Well, my relatives, of course, and the friends of the, and all of these things, ladies and gentlemen, have been happening and have been documented. That if you know the head of cardiology at the hospital and you play golf with them, you get your surgery done. And if you are a physician, you get your stent put in as soon as you hit the hospital when you need it, when you have a heart attack. And if you're a nurse and you're inside the system, you know who the good ones are and who the bad ones are. You don't send your loved ones to people who are likely to off them. And so you get inside information and you use it. All of the things that happen when you have a centrally planned system. And why are we surprised? We watched the slow motion decay of the Soviet Union over 70 years. We watched them go zzz. And that's the principle that is contained in the Canadian healthcare system and is now going to be contained in your healthcare system if you do it. I guess I'm running out of time. I promise. Well, and by the way, we're not the only ones who are saying this. These are all the commissions that none of them mentioned, by the way, in the Blue Ribbon Commission's report, staggeringly. I mean, we have had this has been the main thing that has preoccupied the Canadian population for the last half decade is the decay of our healthcare system, and not a mention, not a peep, not one jit, not one tottle of mention in the report. I couldn't believe it. And of course, these are the private sector people who've mentioned the Fraser Institute since 1990 and CD Howe. I mean, this is all right across the spectrum. We got people concerned about it. Now, I don't have time now to go into this in any detail, but the problem is overutilization and moral hazard. The cause of that is first dollar coverage, universal public subsidy, and what we need is user fees. We need eligibility for public subsidy. You cannot afford, ladies and gentlemen, in Bahamas or Canada or anywhere else to say everybody is going to get exactly the same quality of health care and it's going to be universally applied and without any limitation. If I said that about automobiles, you would say, of course you can't, right? You would say you can't give automobiles to everybody without limitation. You can't give houses. Why doesn't everybody in Bahamas have unlimited access to food and booze, for that matter? Why not? Because you can't do it. And you can't do it with health care either. And so you got to make choices. The pretense that's built into the Blue Ribbon Commission's report is that you pretend that you can give this universally, comprehensively to everybody. It's a mythology that you should look at very carefully and look at the Canadian example. Inadequate insurance protection. Of course we got inadequate insurance protection in Canada and we're not delivering care because why? Because we're insuring oil changes. If you went to your insurance company and said, you know, I got this automobile insurance and it only covers me when I have an accident. Why don't you cover my oil changes? And my tires when they wear out? Why not? Well, it's pretty obvious, right? It's stupid to buy insurance for something you know you're going to have to do all the time. Well, why are we pretending that you need to insure people for going to see their family doctor on a semi-annual basis or whatever it takes when they get bad flu or whatever? Why should we do that? We know that that's a recurring cost of just doing business. And we shouldn't include an insurance plan. Insurance plans should cover you from catastrophe, like your house insurance does, like your automobile insurance does. And the attempt to provide first dollar coverage for oil changes is going to kill our system just as it would kill yours if you adopt it. The inefficient allocation of resources. Well, if you get central planning involved, surely we don't need any more evidence that central planning doesn't work. You know, they tried it. They did the best they could in Russia. They were hanging the guy who ran the grocery store in Moscow to make it work better. He didn't make it work right. He had black market activity going on in the back, so they hung him. Now, you can't have a better incentive than that to get people if you're going to try and force people to do things. It doesn't work. You can't force people to do stuff. You got to get people to cooperate and do what's in their interest because they're led by incentives to do so. And that's why you have to get rid of this central planning idea. The absence of payer accountability. Well, if you have public monopoly in health insurance and you don't have any user fees and you don't have any involvement by the consumer, you have a situation where the government is going to decide everything. The money will go from the taxpayer into the government and then into this new thing that they're going to create. And then they will give the money to the provider. Well, where does the customer come in all of this? There isn't. There's no connection between the customer and the delivery of the service. And that is something that in Canada has caused us endless grief, and it will cause you it as well. And undercapitalization. We have got terrible access to technology, as I pointed out to you, and one of the reasons is that the decision to buy an MRI machine has to go up against the decision to build a new bridge, to build a road in the constituents in the riding of the Minister of Health. Who's going to win? Some airy-fairy plan to buy an MRI machine, or the very practical politics of solving the ward problem? Don't put your health care funding capitalization decisions in the hands of politicians, ladies and gentlemen. That's the number one thing you can learn from Canada. Don't do it. They'll do as they did in Saskatchewan. They'll build hospitals in every square mile of the place as long as they'll buy them votes, and then they won't fund them. They can't. They won't have the money. So these things will be edifices all around. Recently in Saskatchewan, they closed thousands of hospital beds. Finally, when they said, you know what, this is all a myth and a charade. We can't have a bypass surgery center in every town of 400 people. Right? But that's what they did. They built all these hospitals and then couldn't do it. And it was actually unsafe for people because they had hospitals where people were trying to do things where they shouldn't have been. You know? I mean, if they had to put a shingle out, you know, George's General Surgery, you know, carbuncles to cardiac care, you know, I mean, it wouldn't, but that's what happens when you have these small hospitals where people, you know, jack of all trades, the physician doing all this different kind of stuff, that you shouldn't be doing that. So it's not good for your health, and it's certainly not good to let the government get in and capitalize things. Okay. Canadian system is not the one to copy. I'm very nearly finished now. But what should be done? Let's consider the recommendations of the Blue Ribbon Panel. Universal health insurance should be universal. I agree, absolutely. Health care insurance must be legislated, that is to say, not optional for residents. I agree. Why do I agree with that as a libertarian by sort of gut instinct? Why do I agree that there should be compulsion with regard to health care? The reason I agree that there should be compulsion with regard to health insurance is that we are, as a society, not prepared. We're not prepared to say, if you don't buy your health insurance, tough luck. We are always, and it's quite appropriate, we're always going to help. We're always going to be the Good Samaritan. But on the financial side of the Good Samaritan is what? Is the robber baron. The person who deliberately says, well, I'm not going to pay insurance because I know they're going to help me if I need it. And then who pays for it? All of the other people who buy insurance. So the only way to do it properly is to make it universal so that everybody has to pay for the care. Because that's the way in which we're going to behave when the care is needed. Now, national health insurance should be administered by the National Insurance Board. This is not okay. It is not okay. The Commission itself noted that the National Insurance Bureau is hopelessly inefficient, 25% overstaffed. And they apparently think that this is coincidental, because they go on to say that the inefficiencies of the NIB will have to be dealt with. Well, of course that's true, but how are they going to be dealt with? How did they get there in the first place? No discussion of this. Was it just a mistake? No, it was absolutely deliberate that when people are given a monopoly, that's the way in which they behave. The evidence on this is profound and it's pervasive, and there shouldn't be any question about it. So the idea that this NIB is going to solve your health insurance problem in the Bahamas is nonsense. They're going to blow a lot of dough, and they're not going to provide you with what you want. So don't go that way. The Commission doesn't question the central planning model and the hidden costs of monopoly. What are some of the hidden costs of monopoly? If I said to you, you know, all of this expensive, because they make a lot of comment about this in the paper, they note the study from Harvard that, you know, if you have a national single-payer system, you can reduce your cost of administration. Now, let's suppose we were talking about breakfast cereal. Would anybody in this room, or indeed anybody in the Bahamas, vote for a politician who said, we need to have one supplier of breakfast cereal because that way we'll reduce the cost and improve the quality. Now, who would vote for such an idiot? Nobody. Everybody knows that you couldn't have one supplier of breakfast cereal. For one thing, people have different tastes in breakfast cereals. And they would immediately think, would they want to eliminate my, whatever it is that they eat, their, I've forgotten, I don't eat breakfast cereals, so I don't know what the names are, but, my Raisin Bran, yeah. Would they want to eliminate my Raisin Bran? So they would, they would be skeptical about it. Now, if you said, we got a lot of inefficiency of the automobiles. We got a Chrysler dealer, we got a Ford dealer, we got a Volkswagen dealer, we got a Volvo dealer, we got a Mercedes dealer. Imagine all the paperwork that goes into administering all of those different competing suppliers of automobiles, right? We could save a lot of administrative cost by just having one producer of automobiles. Nobody takes that kind of crap seriously anymore. The Blue Ribbon Commission did. The Blue Ribbon Commission said that if we can eliminate all of this competition, we can save costs. And look at the Canadian system. The Canadian system only costs 1%. The administrative costs of the Canadian healthcare system, they reliably implied were just 1%. Well, they needed to come and have a closer look at the Canadian healthcare system. The number one thing you need to remember is that the quality is not constant. The product is not. The reason why you don't want to have one automobile producer and have all that inefficient different. The reason why you want to have them is because competition is not inefficient. It produces better quality. It makes sure the automobiles are there. Not like in the Soviet Union where you had to order one 15 years in advance and all that kind of stuff. Monopoly providers don't work. Competition works, and that's why you have to put up with that extra cost of the competition. The NHI, I'm nearly finished. The NHI plan should be comprehensive. Well, this is not okay, and this is the final point that I need to make with you today. And this seemingly innocuous provision of the plan is really the one that will do you in. Well, first of all, there's the issue of the cost of insuring for oil change, because what they do say is everything should be included in this plan. We want to be comprehensive, so everything should be included. So you're going to insure for oil changes. That's the number one problem. But the second one is that you're going to eliminate the private option. Now, I don't know how many people here are aware that that's what, in fact, is intended by the program. But what the program says is that private spending will only be permitted for services which exceed or are not covered by the NHI. In other words, you will not be able to pay money in the Bahamas. You will not be able to put your hand in your pocket if the government is not providing the service. It says it's providing, it's included in the comprehensive envelope of the national health insurance, but in fact they're making you wait 5 years for it. You will not be, under this law, if it were to be put in place, you will not be able to take your own money out of your pocket and go to a doctor and get it done, or go to a hospital and get it done. You will not be able to do that. That is what the Supreme Court of Canada was talking about in the Canadian system. That this comprehensive, nationally administered, universally available system precludes the existence of. And why do they want to do that? Well, it's ideological, ladies and gentlemen. They want to make sure what Winston Churchill called the equal distribution of misery. They want to make sure that nobody can opt out. That you, if you're wealthy, of course you can opt out, you can fly to Miami, but you won't be able to do it right here. You won't be able to go down the street and jump the queue and pay for your health care services yourself, if it's covered, if it's notionally covered under the national health insurance. Now, I have to tell you that this little clause, in the case when Hillary Clinton came with her plan in the United States, at the very 11th hour of its consideration, a group of us who were working with the Center for the New West out of Denver discovered this clause in the thing. And we made that available to people, and people finally started to realize what she was trying to do. And that was what killed what they called Hillary Care. Not Hillary Care, Hillary Care, Hillary Care. Hillary Care, it sounds kind of funny. But Hillary Care, yeah. That's what killed it, was the recognition by people that this was what was really proposed. And you need to realize that that is what is being proposed here in the Bahamas. If you think that because they say the public health care system will enter into contracts with private suppliers, that means you're going to have a parallel health care system, forget it. You aren't. They're going to turn your private hospital into a public institution. And they'll do it over a number of years, and what they'll do is this. They'll say, okay, you can produce X number of gallbladders and X number of appendectomies and all that kind of stuff. Okay, so we'll pay you this amount. Okay? That's what the first year. Second year, oh, well, guess what? We're going to reduce that a little bit. Oh, you can't make your budget. Oh, dear. Well, we'll give you a subsidy. Oh, well, now in the fourth year. Oh, well, now that we're giving you a subsidy and we're really determined what you do, it's not much point in having a private thing, is there? Now, you think that what I'm telling you is something that I'm making up. When we went into our program in Canada in 1970, we had mostly private hospitals. They were run by the Salvation Army, they were run by the Catholic Church, they were run by the United Church, they were run by communities, organizations, by Kiwanis clubs, they were run by everybody. They were not for profits, but they were private. We don't have any more private hospitals in Canada. Well, we have some now that are emerging, but of those of that original group, they all got taken over one way or another by the Trojan horse of the finance, which the government provided, and there is no option. This is the provision which is most sinister in the report, and it is the Achilles heel of the Canadian model, and was recently rejected by the Supreme Court of Canada. Finally, contributions set at a level affordable by the majority. Now, that's what the Blue Ribbon Commission says in its summary. It says that there's going to be, that's the words they use, contributions set at a level affordable by the majority. But then when you dig into the detail, what do you find?
Wow, I wish we had time for questions and answers, but I'm going to invite Dr. Sweeting to come up and give the vote of thanks.
Dr. Walker, if this was one of our local church settings,